international and local expert in the field of benign hematology. And he's a consultant hematologist at King Faisal Specialist Hospital. His current talk, he's going to talk to us today about the updates in heparin-induced thrombocytopenia. Dr. Hazza, assalamu alaikum.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure and honor to be with you again today, and my presentation today is on heparin-induced thrombocytopenia. I will start with a brief introduction, then we'll go through some updates and conclusion. Heparin is very commonly used medication, and it is really, we were hoping that with the new drugs that the utilization and the indications for heparin will go away, but it is not. And it will persist to be used, as Dr. Fahd Hamid said, for warfarin for the coming decades. In the hospital setting, so 1/3 of patients in the hospital receive heparin. In addition, thrombocytopenia is very common in the hospital setting. But when both occur, it doesn't mean that this is heparin-induced thrombocytopenia. This is a clinical pathological syndrome caused by antibodies to platelet factor 4 and heparin complex. And it manifests with low platelets and thrombosis. And there is the heparin-associated thrombocytopenia that happens quickly after exposure to heparin in the first few days, and this resolves spontaneously. You can continue the heparin. It does not have any major clinical consequences. But the more serious type of heparin-associated thrombocytopenia is the one that happens after 5 to 14 days of exposure, with 30 to 50% reduction in the platelet count. And this is seen around 1 to 3% of patients receiving heparin. This is an immune-mediated phenomena and is associated with serious risk with regards to thrombosis, limb loss, and death. In the United States, up to 1 trillion units of heparin is used, and I always use 1/10 of the statistics for US to extrapolate for the Saudi usage. So maybe 300 million units of heparin is used in the kingdom hospitals. And so 1/3 of patients are exposed to heparin. And the consequences I've just mentioned about the risk of thrombosis. Also, where heparin is used nowadays, most commonly in the cardiology setting, it is also very common to see abnormal platelet antibodies, heparin antibodies in this setting. So heparin use is seen as is done in around 66% of ST elevated MIs, about 40% of non-ST elevated MI. And again, the antibodies, as I mentioned, in cardiology patients or cardiac interventions are very commonly seen and does not always translate into the presence of heparin-induced thrombocytopenia. So, as mentioned, heparin will remain in our pharmacies, and this is the current indication: cardiac surgery, hemodialysis, valvular disease, and low-molecular heparin is the standard therapy for cancer-associated thrombosis. It's very commonly used in bridging, and some rare indications like antiphospholipid where warfarin may fail. Pathophysiologically, this is, if you imagine this is the heparin, and these are the platelet factor 4 proteins, which is very positively charged protein released from the platelet granules. It binds to heparin, because the heparin is a very highly negatively charged molecule. And somehow this binding leads to exposure of new antigens in the platelet factor 4. and makes it immunogenic in a small percentage of patients with the formation of immunoglobulin specific to the complex of platelet factor 4 and heparin. And this immune complex binds to platelets through the Fc gamma type 2A receptor, and it leads to significant and severe platelet activation that is associated with consumption of platelets and activation of clotting cascade and release of prothrombotic agents that leads to thrombosis. So some terminology, there is a new entity of spontaneous HET, which we will discuss later, and then heparin-induced thrombocytopenia, heparin-induced antibodies, where you have antibodies without thrombosis, and this is seen in heparin exposure or in patients who are exposed with SLE or antiphospholipid antibodies. And then when you have antibodies and thrombocytopenia, this is HET, and if you have HET with thrombosis, this is HITT. And then the antibodies will remain in the circulation for around 3 months, and this is called subclinical HET. And there is another entity called delayed onset HET, where patients is exposed to heparin. They finish their therapeutic indication for heparin. Heparin is stopped, and they come a few weeks later with symptoms of heparin-induced thrombocytopenia. And this possibly is related to the glycosaminoglycans binding that are expressed on the endothelial surface. And basically, the antibodies bind to the endothelium and activate the clotting cascade through that pathway. So I think mentioned the manifestations of HET include thrombocytopenia, venous and arterial thrombosis that can be MI, stroke, peripheral artery occlusion. Microangiopathic hemolytic anemia is seen around 5% of patients with HET. Skin necrosis at the site of injection or remotely. And venous limb gangrene, especially if the patient started on heparin, on warfarin early before the adequate anticoagulation with the non-cross-reacting anticoagulant. Sudden death and ARDS and hemorrhagic adrenal infarction due to adrenal vein thrombosis. Another entity of HET is the acute systemic reaction, which is basically chills, fever, dyspnea, and chest pain, and flushing, and global amnesia that happens with high dose of heparin giving intravenously. And this happens quickly, within 30 minutes to 1 hour after the exposure to heparin. This is an example of skin reactions to heparin. Again, digital gangrene, as you see here. And you can have severe gangrene that leads to amputation. The unfractionated heparin is more likely to cause heparin-induced thrombocytopenia, and it's more likely to happen with intravenous high dose and longer duration of heparin and in females. If you imagine this is a 45-year-old lady with atrial fibrillation who present or admitted to the hospital for surgical procedure. She was bridged with IV unfractionated heparin, and 6 days later her platelet count drops to 75,000 from her baseline of 235. She's not on any other medication, febrile, does she have HET? This is the question that comes to our mind, and I think we have now alerted most of the trainees and colleagues and physicians, so there is an overdiagnosis of HET. So if you look at how many patients tested for HET, what fraction of them will truly have HET or positive ELISA testing? What do you think? Maybe 5%. Yeah. So I'm just introducing this case to tell you that clinical assessment alone by itself is not enough to diagnose heparin-induced thrombocytopenia. There's a wide list of differential diagnoses, including DIC, not specifically related to this patient, but this is the list of different conditions that can cause heparin-induced thrombocytopenia. So diagnosis depends on both clinical and laboratory features, and the clinical diagnosis is not easy because there is, especially in the ICU setting, where there are many other medications that are on board, infection, sepsis, DIC, and possible use of renal replacement therapy. All of these may contribute to thrombocytopenia. So for this reason, Ted Warkentin and Andreas Greinacher from Germany proposed a pretest probability model called the T scoring system, which I'm sure you all are aware of, basically looking at thrombocytopenia, the severity and the nadir, and the timing of thrombocytopenia, and the presence or absence of thrombosis, and the presence of absence of other factors. And you give a score, and I always use an application in the iPhone or the Android system to judge the score of the individual patients. Another pretest probability clinical assessment is called heparin-induced thrombocytopenia expert probability score. This is an expert opinion assigned 8 clinical features of the heparin-induced thrombocytopenia, and gives much more details of the diagnostic criteria, and yields in the first publication 100% sensitivity and 60% specificity, and seem to be better for pretest probability compared to 4T scoring. But it's not widely used. This is it's very extensive, and there's also an application for HEP model. But some studies have shown that it does give higher predictability of the hit positivity by ELISA and specific testing compared to 4T scoring system. But I think this also varies depending on the center where it is done. So I use the app always to check the scoring. This patient needs further testing. So she has the appropriate timing for onset of HIT. She has no other medications. So she likely has heparin-induced thrombocytopenia. So what would you do to confirm or rule in or rule out HIT? What tests are available? Fahad, what do you use, Dr. Fahad? ELISA? You use ELISA in the... and do you have the functional assay here, Dr. Muhammad? Okay. Yes. So these are the tests that can be used to diagnose heparin-induced thrombocytopenia. In our hospital, we have ELISA, and we used to have particle gel immunoassay called diamide gel. And there are also, this is called the gold standard test, the serotonin release assay, but this is not readily available, and we don't have it in our hospital. And then the heparin-induced platelet aggregation visual which basically relies on visual assessment of platelet aggregation and the flow cytometry. So practically in our institution, we use ELISA and another gel assay. We used to have diamide gel, but this is another gel assay that basically platelet factor 4 bound to heparin, and you add the serum of the patient and spin it and see if it precipitates or not. So ELISA practically is the test that we all are forced to use, because the more, the gold standard is not readily available. But not all positive ELISAs are the same. Optical density positivity makes a huge difference in the further confirmation if you have the serotonin release assay. So the highest optical density correlates to almost 100% positivity by the serotonin release assay, and the lower ones correlate very poorly with positive assay. So if you have low positive optical density, you may just ignore the test if you have low pre-test clinical probability. In this study, they very nicely evaluated the evolution of HIT. So it starts basically after exposure of heparin to antibody formation, and then beginning of thrombocytopenia, and then further reduction, and then the thrombotic events. And this correlates nicely with the optical density. As the clinical sequelae evolves, the optical density of the ELISA increases. And HIT is not all positive antibodies. This is the iceberg model. Basically, you can have the positive testing without clinical manifestations, or you can have thrombocytopenia with the positive test, or thrombocytopenia with thrombosis. And this varies depending on the drug. It is higher with heparin than low molecular heparin. And I think from the Parinox, there's 1 or 2 anecdotal case reports, and I have doubt that this was truly HIT in these patients. And the patients also vary in their risk for developing of HET. It is much likely to have clinical HET in orthopedic patients than in cardiac surgery, and more likely than in medical patients or obstetric patients. So if you suspect HET and you confirm it, you do the pretest probability, you do the scoring, and you find high or intermediate score, you stop heparin, and you do the ELISA, and if it's positive, you treat as HET. If you have the facility, you can do the confirmation, but if you have positive ELISA, especially high optical density and high clinical probability or intermediate, we treat as HET. A negative HET assay by ELISA, we observe and repeat. It says here exclude. If you have low clinical probability and you are uncertain of the score, you do the ELISA, and if the optical density is high, you may do the functional assay or treat as HET. But this is from a blood publication in 2016. But I think we really have to modify this algorithm based on the availability of the ELISA, the serotonin release assay. So clinically, if you have low score and negative test, easy decision, you don't go any further. But if you have low clinical probability and positive ELISA, depending on the optical density, you can take further decisions. So if you have high probability, low probability and high optical density, I would err towards treating as HET. So this patient has HET, and therapeutic options available in our pharmacies are, our management includes discontinuing heparin or low molecular heparin and initiation of non-cross-reacting anticoagulant, which is listed here. In our hospital, we have argatroban, and we use fondaparinux often whenever there is no renal impairment or any other contraindication. And we have anecdotally used the target-specific low oral anticoagulants. Lipiridine is not available anywhere in the world now. Danaproid is not available in the States or in the country or in Europe. I think it's only available now in Australia. The company stopped producing it. Yeah. So you choose the drug depending on the clinical features of the patient. So you can choose between argatroban and fondaparinux. If you have someone with renal insufficiency, argatroban may be a better choice. Hepatic insufficiency, fondaparinux. And a patient with renal and hepatic impairment may use adjusted dose argatroban and bivalirudin. And the ICU setting, if you look at the pre-printed available dosing schedule for argatroban, most of the time you end up using only 1/4 of the recommended dose, both maintenance and the bolus. And many times you often, omit the bolus in ICU setting because they have multi-organ disorders and liver impairment and other coagulopathy. Now, moving to the update, last week there was an American Society of Hematology meeting in San Diego. I did not attend, but I had the privilege to review the update presented in that meeting. So there was some update on the pathogenesis and the epidemiology and on clinical features, as well as diagnostic strategies. We mentioned the HEP score and the use of target-specific oral anticoagulants. On the pathogenesis, we know the heparin platelet factor 4 complex and the antibodies. The study here showed that this activation is complement dependent, and that in the future we may be able to use some complement inhibitory process to halt or reduce the manifestations and complications of heparin-induced thrombocytopenia. So this is the only one practical aspect of the complement activation process that is confirmed. Also, the immunogenicity of the complement and binding to CD21 receptor in the B lymphocytes. So this can have, as I said, it can be used as a biomarker where complement inhibition and complement binding to the CD21 may be used as a predictor for the development of the HET in patients who just have the, before the clinical manifestations evolve. Another finding is the relation of monocyte involvement in the process of the thrombosis. And basically, it's very nice and interesting study. I'll show you here. They used a liquid chamber here, and they coated it with vulnerable blunt factor, which catches platelets as you pass them through the chamber. And if you pass the platelets through this chamber and add HET antibodies to it, you see the intense activation of platelets here, marked by the green color in this coding here, and extensive fibrin deposition, indicating activation of the coagulation cascade. Now, what is very interesting in this study is that if you see, when they pass the whole blood through this chamber, this is what we get. But if you deplete the whole blood from monocytes, you go back to a picture similar to this, where there is the fibrin formation and generation is significantly reduced. And if you replete the chamber with monocytes, you also get significant regeneration of fibrin. So some form of monocyte inhibitory antibodies may be, a future therapeutic choice. Another interesting finding here is not really new, but basically looking at the risk of heparin-induced thrombocytopenia in low molecular heparin compared to unfractionated heparin, so it's 10 times higher. So in this author, what they did, I think this was in Sunnybrook in Canada, where they systematically replaced unfractionated heparin with low molecular heparin. And they did this without notifying the physicians. Whenever they ordered it, they changed the order to the low molecular heparin. And they removed the heparin and saline flushes and replaced it with saline. So they modified the orders of all physicians using the unfractionated heparin. And this is what they found. These are the years before this modification, 2006. And this is the start of their Avoid Heparin implementation course. And then they looked at the chance of heparin hit, or HI-TT, and you see a very nice reduction in the risk of development of heparin-induced thrombocytopenia and thrombosis. And this is shown here, basically, again here, almost 80% reduction in HET and 40% reduction in suspected HET, and 60% reduction in the positive ELISA testing by just moving or discontinuing and removing heparin from the practice in that center. And there was a close to 1 million Saudi riyal saving in that single institution. Another finding in the ASH last week was the description of what is called spontaneous HET, which doesn't make any sense. Someone who does not have exposure to heparin, why should he develop HET? But their theory is that there is a glycosaminoglycans expressed on the endothelial surface, and because for one reason or another, some people, like many other autoimmune diseases, develop antibodies to the complex of platelet factor 4 release from normal platelets to the glycosaminoglycans, and this leads to the manifestations of what is called spontaneous HET in patients who have no prior exposure to heparin, and they could have antecedent orthopedic surgery or infections. Platelet counts usually much lower than classic HET, and they may develop thrombosis like HET patients, and they have positive testing for heparin-induced thrombocytopenia. And it's very high risk disorder where mortality is 50%. So I think this is from Ted Warkentin describing the details of what spontaneous HET means. Basically, unexplained thrombocytopenia with lack of proximate heparin exposure and positive laboratory features for HET. So it may be an autoimmune process caused by autoreactive antibodies. Now, moving to the last part of the update is the target-specific oral anticoagulants in cases of heparin-induced thrombocytopenia, and there are two case series or two presentation or publications. One is this from I think it's from Iran, retrospective study of 22 patients. They used dabigatran, rivaroxaban, and apixaban in the standard dosing. And their outcome is that there was no bleeding, no recurrent thrombosis, arterial or venous. But the limitation in this case series was that this is a heterogeneous group. Two of them had no definitive pathological confirmation because their tests was not available. This is a better design of the study, basically a prospective trial looking at rivaroxaban use in heparin-induced thrombocytopenia. So they screened 527 patients with suspected HET, and they did 4T scoring system. They ended up having 22 patients with suspected HET. Some of them came back negative, and then they ended with 12 patients who had developed heparin-induced thrombocytopenia. In these patients, the mean serotonin release assay was 95%, which is very highly significant. And their outcome was that 9 out of 10 patients achieved platelet recovery at a median of 11 days. One patient had recurrent thrombosis, and one patient had worsening arterial thrombosis and required below-knee amputation. So, in conclusion, HET is the most profound thrombophilic disorder, 50% in 1 month chance of developing thrombosis. This is very profound thrombophilia. HET remains an important clinical problem. In spite of the development of new oral anticoagulants and other therapeutic options, we will still have be entertaining the possibility of HET because in our country we use bovine heparin, not porcine, unfortunately, heparin. And this is also another risk. I think there was a 7-fold higher risk of HET with bovine than in porcine unfractionated heparin. If HET is confirmed, lifelong avoidance of heparin is required. Non-cross-reacting anticoagulants should be used. Target-specific oral anticoagulants have the role in the treatment of HET. I think the use of low-molecular heparin, fondaparinux, and target-specific oral anticoagulants will hopefully reduce the risk of HET and should be encouraged when indicated. Thank you very much for your attention.
Thank you, Dr. Hazza. We'd like to call all the previous speakers to the stage for questions and answer session.